Can we start, sir?
It's now only 7 o'clock, Dr. Alim. We'll get some gross
Yes.
time of 5 minutes for people to join.
Yes, yes.
And then, and you'll finish in 1 hour. We don't
Yes,
have,
yes.
people are joining, so give them 5 minutes time, please. So Magesh, you will give some introduction talk, then I will give some 2 minutes introduction talk, then we'll go to the topic.
Yes, sir. Yes, sir.
You talk for 1 or 2 minutes, then I will give 1 or 2 minutes, and we'll hand out to the chairpersons. I'll introduce
Yes,
the
sir, yes,
chairperson, I'll hand out to them.
Yes, sir. Yes, sir. 7
Then
5.
they will start the session, then we'll start talking.
Okay, sir.
And you coordinate the questions from the, once you finish coordinate.
Yes, sir.
The chairpersons are there, they will coordinate this.
Yes, sir.
So then we'll conclude. So we'll leave it to the chairpersons after we introduce and
Yes, sir. Yes.
concluding remarks will. Thank you. Maybe I will start the introductory remarks. I'll give it to Dr. Magesh. And then once it is finished, I will give it by the time that people will be joining, it will take 5 minutes to finish. Then we'll start the lectures. Okay. Hand out to Dr. Magesh, Vice Chair, Rare Disease, Subsection, Indian Academy of Neurology.
Good evening, all. We welcome you for this rare disease subsection meeting on this Sunday evening. So there will be 2 talks, either one by Professor Dr. Parani on yoga therapy in neurology, and then second by me by congenital myasthenic syndromes. We welcome our chairpersons, Professor Dr. Alim and Dr. T. Muthu and Dr. T.C.R. Ramakrishnan to proceed with the sessions. Now, Professor Dr. Parani will introduce the chairpersons and others. Yes, sir.
Thank you. Thank you very much, Dr. Magesh. And we took over the rare disease last year, and we conducted the business meeting. Subsequently, we done rare disease day meeting, and we done a meeting on rare diseases. So this is 3rd meeting we are conducting, and all the chairpersons are members of the Indian Rare Disease section of Indian Academy of Neurology. I'm thankful to Dr. Muthu, Senior Consultant Neurologist at Vellore, Professor M.E. Alim, Senior Consultant Neurologist at Trichy, and Dr. Ramakrishnan, Consultant Neurologist, Senior Consultant Neurologist at Coimbatore. So we have people from different places, and it is very short brief, so that we will not bore with for a long time. So there are only going to be 2 talks. So I'll hand over to the hand over session to the chairpersons for them to start the seminar. Thank you very much.
Thank you, sir. I am Dr. Alim. Thank you very much for giving me this opportunity. I welcome all the participants and the members, those who are joining this meet. The first topic is on the rare disease, neuromuscular disorders, and yoga. This is going to given by a yoga guru, Palani sir. He had many laurels. I invite him to deliver this lecture, sir.
Thank you very much, Professor Alim. And I'll share the platform. Give me a minute. Thank you very much. I thank Indian Academy of Neurology for and the staffs for arranging this CME on rare neurological disorders. And the importance, even though it is rare, it is not really rare. There are millions of people affected by many rare neurological disorders because the number of rare neurological disorders are so vast. So basically, it is not rare by itself. The individual diseases are rare. So I'm going to focus mainly into yoga therapy in rare neuromuscular disorders because we see in our practice day to day that we are not able to help therapeutically many patients with some other neurological disorders. But there are so many ways we can help them by rehabilitating measures, the way to live and how to take care of them. So it is more like a multidisciplinary teamwork. So one of the concept is yoga therapy. It's picking up all over the world. And it is very simple to practice. It can be practiced at home. We need a mat and we need to know what to do. And we need just to attend to the supervisors. Because there are times that people don't have access to physiotherapy and other therapeutic measures. And they depend upon what they can perform and what they can do without much cost issues involved. This is one of the important measure, which is, and the yoga therapy department is there in many medical college hospitals. And it is there in many neurological hospitals or many medical hospitals all over the world. So I'll just talk, I'm going to talk on yoga therapy in rare neuromuscular disorders. So rare neuromuscular, I'm not going to tell about any specific disease. You know about what is neuromuscular disorders. Rare neuromuscular disorders are a diverse group of progressive conditions affecting the nerves, muscles, or the junction where they meet, leading to chronic weakness, wasting, and loss of motor control. Now, there are some diseases you can give some partial treatment. There are some diseases you have to depend upon rehabilitative measures. Many are genetic or autoimmune origin and can manifest at any stage of life from infancy to adulthood. Motor neuron diseases, the spinal muscular atrophy, and rare variants affecting nerve cells in the spinal cord and brainstem. Even though there are now, we are getting some therapeutic measures for some other rare neurological disorders, which has a partial benefit, and they totally depend on rehabilitation, other lifestyle modification issues. The inherited myopathies are congenital distal myopathy, pneumonic myopathy. There are so many myopathies, so many rare disorders are there. I don't want to list it now. So the neuromuscular junction disorder like Lambert-Eaton syndrome, a rare congenital myasthenic syndrome that block nerve to muscle signal transmission, and peripheral nerve disorder. You know, there are many genetic neuropathies and many other rare neurological neuropathy disorders you know of. So we know that they have a weakness in the limbs, face, or core muscles, muscle wasting, cramps or stiffness, fatigue and severe exercise intolerance, difficulty in swallowing, speaking, or breathing in advanced stages. So yoga therapy is applying yoga as a therapeutic intervention, understanding the underlying disease, and teaching the patient what they can do rather than pushing something into the patients they cannot do. So yoga therapy serves as a complementary, low-impact approach to help manage symptoms of rare neuromuscular disorders by improving flexibility, easing muscle tension, and enhancing mind-body coping mechanisms. It does not cure degenerative or genetic conditions, but personalized movement and breathing practices can support daily physical function. Reduced spasticity, gentle stretching helps relax tight or contracted muscles. People can do it by themselves. They don't need another person to do unless they are physically disabled totally. They need some help from others. Many people with rare neuromuscular disorders, they live with the disease for quite significant time. And a lot of things they can do by themselves. By teaching simple measures, they can do it. Improved balance, seated or property supported postures. We always worry that after a particular age, how can I do a particular asana or particular postures? Kindly understand there is something called properties. Yoga, you can do yoga by assisted properties. You can go to any sports shops, you will get a lot of assisted devices like chair and brick-like things. I'll show the photographs of that, which you can use, and you can have some string, plastic string, you can attach to the feet, you can push it up to your side gently, not without rupturing the muscle. So there are some lot of properties available for people who have difficulty in doing some asanas, and this can partially help, but better not to avoid overstretching. Enhanced breathing like pranayama strengthens the respiratory muscles often compromised in neuromuscular diseases, because we know these people have respiratory issues, they can have hypopnea and they can have apnea at night, and many people have some kind of sleep disorders, and that can affect their cognition because of a lack of oxygen, or they can produce much more grogginess or weakness in the morning. Stress and pain relief, meditation, relaxation, down-regulate the nervous system to ease chronic discomfort. Because when people have chronic disease, they will be under extreme anxiety or stress that can produce a lot of down-regulation in the body, and the effect on the neurotransmitters and so many things it can do to the body. We know that emotion and anxiety has a lot of damaging effect on the body function. So work with a specialist. It's very important to tell people that to decide what kind of intervention the patient can do. You need a multidisciplinary team. The specialist who is managing the patient should go through the list of the things which is recommended for the patient. Always consult a neurologist before starting and seek a certified, and also ask a certified yoga therapist who is properly qualified, experienced clinical or neurological population. So you need a multidisciplinary approach to decide what is ideal for a particular patient, for a particular disease. Use modifications, rely on chairs. For example, I cannot do things on standing yogasana or sitting yogasana. I can sit in the chair and do what I can do. So it's called chair yogasana. Straps, you can use straps to attach your feet or hand, and you can use that gently to do some exercise. And blocks, I will show the photograph. Avoid deep or aggressive stretches that risk joint instability or overexertion. We have to understand how strong the muscles, how strong the tendons, how joints are well placed within the cavity. Suppose if we do overdo, we can get into some other problems. So monitor fatigue, neuromuscular conditions, future rapid muscle exhaustion. Keep sessions short and stop before tiring effort. I always tell people that don't do for longer time. People always say do yoga for 1 hour, 1.5 hours, meditation for half an hour. All those things, even normal people get fatigued and they lose interest in doing yogic practices. So recently I done some 3 minutes of meditation and 5 minutes of pranayama, 8 minutes totally. Anybody can do in the chair sitting position. I recommended for all software engineers, everybody. And this resource is also in the WHO website. Recently, I've been appointed as a commissioner for WHO, Lancet Neurology Commission, Neurorehabilitation. Their resource also having this 8 minutes of video clip. And you can see in the YouTube and put my name and put simple meditation pranayama technique, you can get that. So the neuromuscular conditions feature rapid muscle exhaustion. We have to keep that in mind. We should not give a prolonged sessions or tiring sessions to the people. Keep sessions short and stop before over tiring at us. Adaptive and chair yoga modifies traditional poses using properties like chairs, straps, and blocks to accommodate severe muscle weakness or balance issues safely. Pranayama employs controlled slow breathing techniques to support respiratory muscle function, decrease anxiety, and lower physiological stress. Whenever you do anything like breathing technique or meditation technique or muscle stretching technique, yoga means it has to be done very, very slowly. No need to do very faster. It is not to show our physical capacity. That's not the purpose of yoga. Yoga should be done very, very slowly. Even breathing technique has to be applied very slowly. To take a slow deep in and slow deep out actually. So very important. We should not be doing very faster. It has a lot of other issues if we do faster. So gentle somatic movement focuses on slow, mindful re-education of muscle groups to release chronic tension and address spasticity. So do the movement very slowly. We have to do the movement very slowly. We should not fight against the muscle, and we should not fight against the tendon. And the patient say, I have pain. We are better to be very, very careful. We should not produce pain, and that can produce, especially muscle weakness patient, some kind of tear in the muscles or some tear in the tendons. Restorative postures. Use bolsters and blankets for passive stretching, minimizing overexertion while promoting joint flexibility. So mobility support helps maintain range of motion in the hips, knees, and ankles, aiding gait and short distance walking. We know that we move by joints, and the joints need muscles and tendons. So we have to keep everything in mind that when we are doing yoga therapy, that we have to take care of the tendons, take care of the muscles, and we have to take care of the fascia and take care of the joints. Pain and fatigue reduction is lowest perceived physical discomfort and systemic stress markers. And we have been going on doing prolonged things will produce a lot of pain and fatigue, which we should avoid. Not only in yoga therapy, any kind of rehabilitative measures. Respiratory efficiency enhances vital capacity through specialized chest and diaphragm expansion techniques. We know that in neuromuscular disorder, the main important muscle is diaphragm, which is the main respiratory muscle. We have to keep in mind that we have to give exercise to the diaphragm and the intercostal muscles and the other muscles of respiration. So meditation serves as a valuable complementary mind-body tool for people with rare neuromuscular disorders, helping to reduce stress, manage chronic discomfort, and improve overall emotional well-being without interfering with physical function. You don't need much effort to do a meditation. There are simple meditation techniques which I will tell you about. Lower stress helps calm the nervous system and lower stress hormones that can otherwise worsen fatigue and muscle tension. Manages pain, separates the physical sensation of pain from the emotional reaction, making discomfort easier to cope with. So the patient can handle better if they have a better emotional control. Improves the sleep, promotes relaxation, and helps quiet the mind before rest. It's better to take and do some of the meditation before going to bed. They can have a peaceful sleep, and some of the like deep out breathing. And better if you do pranayama, the stomach should be free from food for minimum 3 hours. So better to eat at 7 o'clock. So 10 o'clock, if they do it, will be fine. Some simple measures. Boost mood, reduces anxiety and feelings of isolation common in rare or chronic illness. We have to keep in mind the emotional component to a normal person is different from people with rare neuromuscular disorders or any rare diseases. They are having the disease for a long time. They may have less social support and they have depression of having chronic illness. So many problems are there. So they need a holistic care. So start small, always begin short 5 to 10 minute daily sessions rather than long blocks of time. Modify the posture. You do not need to sit cross-legged. Practice while comfortably reclined in a bed or supported in a chair. You always get into a position of, always make the patient get into a position of ease and they should not be in pain while doing any procedure. Focus on gentle breathing. Use simple natural breath awareness instead of forced deep breathing exercise if respiratory muscles are weak. We have to keep in mind, we have to stretch the weak muscles very, very slowly. And use audio guides, specialist apps like Insight Timer or programs through advocacy groups like the Neuromuscular Disease Foundation offer guided relaxation tailored for chronic conditions. Listening to your light music, listening to light song, or something which you like to listen, which doesn't disturb your mood or your emotion. So pranayama serves as a gentle, complementary approach for managing respiratory efficiency, stress and autonomic balance in selected neuromuscular conditions such as muscular dystrophies or SMA, but it must be practiced with extreme caution under professional medical supervision. So you need to teach them there. Somebody knows yoga, somebody in neurological disorder, there's a team work, like multidisciplinary team. They should teach the patient how to practice. They should design or they should tell how to carry out in the home atmosphere, domestic atmosphere. So respiratory muscle support, controlled slow breathing exercise can help maintain chest wall compliance and optimize the use of remaining diaphragmatic and intercostal muscle function. We know that the diaphragm is not totally paralyzed. So the
So any audio issues?
Yes, I'm not able to hear.
You're not able to hear?
Yes.
Yes, sir. Not now we are able to hear.
Okay. So it lower physiological stress and promote parasympathetic dominance. Symptom management like practices like Brahmari, humming bee breath. Brahmari is practiced in India for 5,000 years. And it is a humming bee breath or black bee sound, a ringing sound of black bee. And it is like that. You have to do like this. You put your thumb in the ear hole and spread the finger across the face. It's called Shanmukhi Mutra. You make a humming bee noise like this. This is called Brahmari. It makes the brain to secrete neurotransmitters. It gives peaceful sleep. It improves the voice quality. It improves our immunity. It improves our memory. So many benefits of practicing Brahmari. So it can be practiced in any sitting in the chair itself. So muscle fatigue, overexertion of weakened respiratory muscles can lead to rapid fatigue or carbon dioxide retention. Avoid forced retention. When you are doing a breathing techniques involving forceful breath retention like Kumbhaka or intense abdominal locks like Bandhas are generally contraindicated. Don't do any difficult, bandha means locking off. That for example, you contract a muscle and holding for some time, then relaxing is called bandha. This is practiced in a thing called Mula Bandha. I don't know how many of you are aware of that. Kegel's exercise is nothing but a Mula Bandha. People hold the sphincter for some time, hold it for some time, then they relax. That is a kind of bandha. And Kumbhaka, so they never do alternate nostril breathing or Nadi Sudhi. Nadi Sudhi is only alternate nostril breathing and you don't return the air. Nadi Sodhan is you will be returning the air. So any cardiac condition or people with neuromuscular disorders, don't do Nadi Sodhan, you do only Nadi Sudhi. You take a deep inhalation one side and exhale the other side. For example, you use this technique, block the right nostril and the hand in the left hand in the Dhyan Mudra, Chin Mudra, inhale through the left nostril, lock and exhale to the right nostril. Inhale to the right nostril, lock and exhale to the left nostril. This is called alternate nostril breathing or Nadi Sudhi. It opens the nostril. Many people have nostril blocked, they get relieved and the lung get expanded and oxygen concentration in the body improves. It has a lot of health benefits to the body. It gives energy to the body. Individualized capacity. Exercise must be adapted to the patient's baseline forced vital capacity and specific neuromuscular limitations. Always assess the respiratory parameters and adjust the breathing techniques according to that. Asanas for rare neuromuscular disorders require extreme care, relying on gentle, supported, and adaptive movements rather than intense or traditional deep stretching. So we have to keep in mind there are 4 types of asana: standing asana, sitting asana, prone asana, supine asana. I think many of these people need assisted devices and lying position, they're very, very comfortable. There are so many asana you can do in sitting and lying position. Safe practices focus on maintaining joint mobility, reducing the muscle tightness, and supporting breathing without over-exhausting compromised muscle fibers. So chair Tadasana, it keeps the spine straight and improves the core awareness while fully supporting the body weight. You lock the fingers like this, keep on the chest. You can do pranayama also along with that. Inhale and exhale. Inhale and exhale. Then go up, inhale and exhale. It's called seated Tadasana. You are doing in the sitting position. What happens is the muscle stiffness from the neck, cervical region up to the bottom of the spine get relaxed. It's called seated mountain pose. Keeps the spine straight and improves the core awareness. Supported bridge nose is Sedu Bandhasana. That is like a bridge. I think that will be difficult for many people, but you can do with assisted devices. Then supine spinal twist. You lie on the supine position and twist the spine a little bit and relieves the back tension, maintains the mild flexibility in the torso while lying safely on a flat surface. Seated forward bend with the straps. That is a Paschimottanasana. That you can use assisted devices you can do. Because some people have a very longer legs and upper body is smaller, then difficult to reach the feet. Then you do reach the place up to what you can reach rather than trying to reach the feet. Stretching is more important. So avoid exhaustion. Stop immediately if you feel muscles shaking, severe fatigue or shortness of breath. Use props. Always use chairs, bolsters and wall supports to eliminate fall risk. Skip deep holds. Never force a limb into a rigid position or hold poses that cause joint pain. Prioritize breathing. Combine slow, mindful breathing with movement to calm the nervous system. Assisted devices in yoga therapy for rare neuromuscular disorders provide vital external support, stability, and safe stretching ranges to prevent contractures without overstraining the fragile muscle fibers. What happens in yoga really is when people have some underlying disability, they become older, they have underlying cardiac condition, they cannot do a lot of things. They always scared that they'll be forced to do something which they cannot do. So I always tell people to do what you can do, don't do what you cannot do. Have some supportive devices. And yoga is not asana. Yoga, the main important thing is meditation, pranayama, and some simple asanas, what you can do in the sitting or in the lying position. So yoga blocks and wedges offer height adjustment and support under the sacrum, hands or knees to reduce weight-bearing stress. Strap and stretch belts assist in gentle passive limb extension for tight or spastic muscles without requiring active muscular exertion. Bolsters and pillows position the body securely during supine or seated austerity postures to maintain proper spinal alignment. Sturdy chair serves as a primary base for adaptive chair yoga, stabilizing the torso for upper body and breathing routines. All these things are available in most of the sports stores. Avoid overstretching. Restrict holds to prevent micro tears in the vulnerable dystrophic muscle tissue. Focus on breathing technique like pranayama. Emphasize respiratory muscle conditioning and relaxation over complex physical shapes. Custom pacing. Tailor movements strictly to individual fatigue thresholds and remaining functional capacity. Yoga facilitates neuroplasticity, the brain's ability to rewire, adapt, and form new neural connections by practicing mindful movement, breath work, and meditation. Regular practice modifies brain structures and enhances cognitive function. Increased gray matter thickness, MRI studies reveal increased gray matter density in the hippocampus and prefrontal cortex, center for executive function attention. Elevated BDNF, yoga increases the production of brain-derived neurotropic factor, a protein that supports the neuron survival and synaptic plasticity. So the main mechanism, asanas, mindful movement improves interoception, the ability to feel internal body signals, rewiring the sensory and motor cortex. I don't know how many of you closed your eyes and focused onto your organs in the body. Like I'm focusing in my brain, I'm focusing into my heart, I'm focusing into my stomach. Like that, you can feel the internal organs by doing this kind of techniques. Pranayama is a slow, intentional breathing, shifts the nervous system from a sympathetic state to a parasympathetic state, reversing the degradation of neural pathways caused by the chronic stress. Meditation strengthens the neural networks linked to emotional regulation and self-awareness while calming the amygdala. Simple practices that have maximum benefit. I mentioned to you about the alternate nostril breathing, Nadi Sadhana. I told you about the black breathing technique. You can go into my YouTube, you can watch that also and practice. So chanting is a powerful acoustic and vibrational therapy. The practice of Om chanting and Aaj chanting. For example, somebody wants to do Om, they can do Om. So because Om is basically sound of the space. It's only a space sound. And Aaj chanting, they actively engage the vagus nerve, which helps to shift the nervous system into relaxed rest and digest state, while physically stimulating the brain areas responsible for emotional regulation. The Ah sound initiated deep in the belly. This sound encourages diaphragmatic breathing, which engages parasympathetic nervous system and start the relaxation process. Om sound is basically a combination of A, U, and transitioning from the deep breathing to resonant hum in the throat and the crown of the head. This auditory and physical vibration stimulates the frontal lobe and activates the default mode network, which leads to improved focus, better emotional processing, and stronger neurological processing and plasticity. Pranayama and neuroplasticity offer a promising non-invasive methods for facilitating the brain's respiratory centers, which are responsible for central sleep apnea. By intentionally modulating breathing, these ancient yogi practices act as a natural form of neuromodulation, helping to rewire neural pathways and recalibrate the autonomic control. Unlike obstructive sleep apnea, which is a mechanical blockage, central sleep apnea occurs when the brain briefly stops sending the signal to breathe. Pranayama can alter this pattern through specific mechanisms. It is a brainstem training. The brainstem is the command center for involuntary breathing. We know that. Consistent conscious breathing practices send sensory feedback, offering inputs to the brainstem and limbic system. Over time, this helps restore a stable rhythmic breathing reflex. Only a few slides more, one or two. Vagus nerve stimulation. Slow pranayama practices stimulate the vagus nerve, increasing parasympathetic tone. This calibrates the autonomic nervous system, preventing the hyperventilation and the sudden drops in CO2 that often triggers a central sleep apnea. That's why I told you have to do breathing techniques to neuromuscular or any neuromuscular disorder patient. Chemical recalibration. Some breathing technique with or without breathing retention stabilize how the body responds to oxygen and carbon dioxide level in the blood, reducing the instability of the breathing during the sleep. So these are some of the papers. This one paper I presented on the role of Yoga Mudra. I also done some work on Yoga Mudra and Bharatanatyam Mudra. This Mudra technique can be used for people with distal weakness in neuromuscular disorders also. And the role of Brahmari and Kechari Mudra in improving the dysarthria, I done in a stroke patient. Some of the study also I have done. And this has a very important technique on calming the emotion. It also has a lot of benefit to the tongue spasticity, tongue weakness, and a lot of breathing also improves with Brahmari technique and Kechari Mudra technique. Brahmari, I have told, Kechari Mudra is to take the tip of the tongue, touch the roof of the palate, and give vibration to the brain. Look at this. And touch the mid palate. I told you, Nadi Sudhi, that this Kechari Mudra, this vibration goes to the midline, to the pineal gland, pituitary gland, hypothalamus. You'll get good sleep. Your hormones will be normal. Your pulse and BP will come into control because it goes up to the hypothalamus. Then I told you about the Brahmari Mudra. And the last one of the important technique is the Bhairava Mudra. Keep the left hand, the palm facing upwards to the umbilicus level, the right one above that. And take the biomagnetic field surrounding the body get locked. Take a slow, deep inhalation, slow, deep exhalation. The breathing travels along the spine, go to the bottom of the spine, called Mooladhara Chakra, where our soul lies in a serpentine shape. It touches the soul, come back to the nostril. So it's called soul ventilation or spine ventilation. And this another technique I used, pranayam, pranamudra and brahmari in reducing the awakening during sleep. And this study on 60 patients. So these are the properties I was telling you can get from sports shop. Yoga mat, and yoga wheel supports the back stretch, improves the flexibility, and yoga belt. You can adjust the length and you can attach and do that. Yoga brick is more soft material. It's not a hard material. You can do, you can use for as a property. Yoga chair, as I mentioned. Aerial hammock is people use for the aerial yoga, like the child lying in the cloth hanging from above. And like that, people lie on that and they do yoga. It's called aerial yoga and rope set. These are all property assisted devices, which has a lot of benefit. People have difficulty in doing, but still you don't do difficult thing, do simple thing what you can do. Thank you for listening to me.
Thank you, sir.
Thank
It
you.
was thank you, sir. It was a elaborate talk on the role of yoga in rare neurological disorders. Sir, you said yoga plays a very important role in regulating the autonomic system. It increases the parasympathetic tone and reduces the sympathetic tone. That's very good for the human body as such. Similarly, does it have a role in the hypothalamic pituitary axis? You also said something about its role in prefrontal cortex. And does it in what way it affects the inflammation? Does it have any role in reducing the inflammatory cytokines or something like that? It was a very nice talk, sir. We enjoyed that.
That
These questions, I think only Pani sir can give clarification.
see that Brahmari Pranayama, which I was telling you, that is practiced for 5,000 years in India. It has it enhances our immunity. And the people like cytokines and all these things become better. It also increases the neurotransmitters. I have practiced myself Brahmari. Whenever I feel tired, I do this in my clinic itself. I teach my patient, every patient I teach. So along with them, I do yoga. I feel more energetic. So I can carry on my work for longer time. And I feel the physiological changes immediately. And I was telling you about the Kechari Mudra. Kechari Mudra, I think you would have noticed that you take the tip of the tongue, touch the roof of the palate, and keep your hand in the Gyan Mudra, Chin Mudra position over your thigh, and touch the tongue to the mid palate and give intermittent vibration to the brain. The vibration exactly travel in the midline. It goes to the pineal gland, pituitary gland, hypothalamus. You will get good sleep. Your hormones will become better, and it also has a control on the pulse rate and the blood pressure, other autonomic things, because hypothalamus we know is the center of autonomic issues also. And we always wonder that what is the evidence for all these things. There is recently one or two case study published by IMS itself on the role of yoga mudra. They done a functional MRI while doing. I not talked about yoga mudra because of time issue, and they found a lot of networking changes while practicing yoga mudra in functional MRI.
Oh.
So we are getting a lot of scientific evidences, and the last year itself I published 10 papers on yoga, all combining studies, and it is cost effective, and it is not going to harm us. It is cheaper, and you can practice in the home. And the only thing what we are always thinking is giving some medicine is treatment. There are so many ways you can handle your body, and you know very well that if we are going to die, we are going to die through our autonomic nervous system. Our sympathetic or parasympathetic will kill us. Tachycardia, bradycardia, hypotension, and we will die. Arrhythmia. So ultimately, we have to die through our autonomic nerve. If you are able to control your autonomic nervous system and your emotion, then we can postpone a lot of things. We can prolong our life quality. So
yes, sir. Thank you, sir. So shall we move to the next topic?
yes, sir.
Excellent talk, Palani sir. It's very
Thank you.
enlightening. Thanks.
Thank you.
So now we will move on to the next topic, talk on congenital myasthenic syndromes. It's always a tough task when we see a child with hypotonia. Yeah, floppy infant is always a challenging thing to diagnose, whether it is a neuromuscular or muscular muscle disease or a nerve pathology. It's going to be a tough thing to diagnose. So here is Magesh sir, who is a leading pediatric neurologist. He is going to enlighten us on congenital myasthenic syndrome. Over to you, sir.
Thank you. Good evening, sir. After a lucid talk on yoga in rare diseases, rare neurological diseases, the next comes the congenital myasthenic syndrome, little complex topic. I'll try to make it as simple as possible. So in this, I'll be discussing about what is congenital myasthenic syndrome and something about the neuromuscular junctions and genes involved. I'm not going in depth to the genes. And then in general presentation of congenital myasthenic syndrome, various ages right from newborn, infancy, early childhood, and even in adults. Then I'll touch upon certain salient features of certain genetic myasthenic syndromes and its management. So, what are congenital myasthenic syndrome? They are inherited non-autoimmune disorders of the neuromuscular transmission, the genetic counterpart of the myasthenia gravis. They have a fatigable weakness right from birth or early childhood or even in adults. So usually they are negative for acetylcholine receptor antibodies and MuSK antibodies, but there are some case reports as recently even they have been positive for anti-acetylcholine receptor antibodies now. So the pathogenic variants are increasing now. Now nearly 40 genes are associated with congenital myasthenic syndrome, right from synaptic, postsynaptic, and presynaptic regions. The estimated prevalence is nearly 1 in 5 lakh population, but the thing is various literature say 1 in 2 lakhs to 5 lakh, but the incidence may increase. The thing is many of the adult seronegative myasthenia gravis, they have been found to have congenital myasthenic syndrome. Those adult myasthenia gravis patients who are seronegative, they are not responding with a showing good response to pyridostigmine. They have been evaluated genetically and then found to have congenital myasthenic syndrome. So the incidence may be increasing if we focus on that. So this is a normal neuromuscular transmission which we know. So whenever action potential comes, there will be an opening of voltage gated calcium channels, entry of calcium ion from the ECF, opening of vesicles and release of acetylcholine into the synaptic cleft. So then in the cleft, they pass through a cleft, they bind to the receptor and forming acetylcholine receptor complex. There will be opening of ligand gated sodium channels, entry of sodium ions from ECF, then there will be end plate potential. Once they cross the threshold, there will be action potential. Then excitation, contraction coupling, and muscle contraction. So these steps, each and every step is governed by genes. Various genes govern these areas, like some in axon terminal, some in synaptic cleft, some in postsynaptic membrane, and muscle fiber. So any mutation in this gene causing defect may affect the neuromuscular transmission and cause congenital myasthenic syndrome. So this is a neuromuscular junction, this is action potential, this is synaptic vesicle crossing that. So these are various areas where we can say this is a presynaptic. There are so many genes controlling these movements of acetylcholine and movement of synaptic vesicles, and then release. So many genes are involved. Then receptors are controlled by various genes. So any mutation, any defect in the gene, inherited defect may cause this congenital myasthenic syndrome. So this is a normal neuromuscular transmission. As I already told you, choline uptake, these genes, they import choline into nerve terminal. The CHAC gene combines choline plus acetyl-CoA to form acetylcholine. This gene loads acetylcholine into synaptic vesicles. Then these protein dock and fuse the vesicle. Then receptor binding happens with the and stabilized by rhabsin and agrin. These names you will be discussing later about the mutations. Rhabsin and agrin, MuSK, DOX7 pathway, then the signal termination. So acetylcholine anchored via CalQ, the hydrolyzes acetylcholine. So these acetylcholine hydrolyzes. So these are the defects. This is the presynaptic defects. This gene caused by this gene. Axon transport is due to defect in myoNA gene. So defect in glycosylation, this is an upcoming field, defect in glycosylation. Apart from presynaptic problem, synaptic type and then postsynaptic mutation, this is a glycosylation is a separate topic. So these are the various genes involved in mutation related to congenital myasthenic syndrome. So the location predicts the phenotype. The thing is, commonest cause of congenital myasthenic syndrome will be postsynaptic, where CHRNE mutation is involved. They are contributing 75% of the myasthenic syndrome. The next one is around 15% is called Q, Llama 5, all these. They operate at the synaptic level. Presynaptic is little rare. And this is an emerging field, a glycosylated defect due to these genes. defective mutation, and GMPPB. So this GMPPB mutation can present as a myopathy. The CPK will be elevated in this mutation. So they may mimic myopathy, but they are actually congenital myasthenic syndrome. So that's why location predicts the phenotype and critically the treatment response also. So they are classified based on anatomical level, presynaptic, synaptic, and postsynaptic or glycosylation defect. Based on inheritance, autosomal dominant or recessive. Most are recessive, and then some are like slow channel syndrome or dominant, and then some are presynaptic. And based on that, nowadays what happens is we call them as gene DOX7 mutation related CMS, all like this. So because each and every gene behaves differently, and the management will differ. So commonly what happens, the name congenital implies right from birth. So what happens is the neonatal presentation, it happens with severe presentations. So there will be respiratory insufficiency with sudden episodic apnea and cyanosis. It commonly happens with presynaptic. Then arthrogryposis multiplex congestion happens, resulting in a lack of fetal movement. Because the fetal movement is affected, there will be a contractions of the major joints. There will be feeding difficulties, poor suck and cry, choking spells. There will be ptosis, facial bulbar weakness will be there. Then stridor, any stridor in infancy, you think of CMS. Though we say the child may have laryngomalacia and all, but still you think of CMS and exclude. And then there may be associated what to say, there will be narrow jaw, high arched palate, or syndromic features associated with this. This is a neonatal presentation. So what happens in early childhood? There will be abnormal muscle fatigability with difficulty in running or climbing stairs, but ACH receptor may be negative. Usually, any child presenting with myasthenia-like symptoms less than 2.5 years, you think of congenital myasthenic syndrome until proved otherwise. So milestone may be delayed. There will fluctuation in ptosis. There will be fluctuating extraocular muscle weakness. Ptosis may be unilateral or bilateral. There may be facial and bulbar weakness with nasal space, and then spinal deformity can happen and muscles may atrophy. This is one type of presentation, limb girdle presentation. This may mimic limb girdle myopathy, but actually a limb girdle myasthenia. This is the commonest presentation which can happen even with adults. So whenever that child presents with limb girdle weakness, you think of congenital myasthenia. And then while doing, you have to include the RNS in the study. So though it is very difficult to do RNS in children, better to include that. Suppose even if it is negative, look for genetics, specifically whether the gene panel has included CMS panel. So do we see CMS in adults? Yes, because there are the presynaptic phenotype, though it is very severe, that may have repetitive apnea and then ventilator recurring, ICU admission and all, but still they overcome and reaches adulthood. As age advances, the severity will be less and then the child reaches adulthood. So definitely adult presentation is there in CMS. Symptoms may be there for suckle for years. There may be exercise intolerance, childhood ptosis, recurrent respiratory events may be there. They have what to say, the late onset rhabdoid mutation can resemble seronegative myasthenia gravis. Typically, DOX7 mutation can produce the limb girdle type of weakness with ptosis, but little or no ophthalmoparesis. And slow channel CMS may present from childhood into adulthood with selective neck. This is specific. There will be selective neck muscle weakness, finger or wrist extensor weakness, and then progressive respiratory involvement. Family history may be negative because many are autosomal recessive. Coming to presynaptic CMS, these are the genes involved. CHAT, SLE5, all these genes are involved in the presynaptic area. The mechanism is the reduced acetylcholine synthesis and transport or vesicular fusion defect causing fewer vesicle release into the cleft. So what happens is the commonest presentation will be episodic apnea. This is characteristic. And cyanotic crisis. Child may cry if in infancy. Any child who is crying frequently without any reason and all, you evaluate for this presynaptic CMS. So look for hypotonia and evaluate genetically. So interictal examination may be normal. Even baseline examination can be normal with mild hypotonia. RNS, if possible, we can do with both before exercise and after exercise. So the thing is, recurrent unexplained apnea with normal intellectual examination in infancy, think of Congenital myasthenic syndrome, not acute life-threatening event. Coming to synaptic CMS, this is one example, CALQ mutation when acetylcholinesterase itself is missing. So this CALQ anchors acetylcholinesterase to the basal lamina. There will be loss of function mutation. So there will be deficiency. So what happens is there will be young plaque cationic overload and secondary myopathy features can also be there. So they can present with limb girdle myasthenia-like weakness. There will be progressive proximal, axial, and ocular weakness. Feeding difficulty. One characteristic finding of CALQ will be there will be a sluggish pupillary response. Yeah, bedside examination, if you are able to see sluggish pupillary response in a child with limb girdle myasthenia, so you can think of this CALQ mutation. The thing is they are often worsened by acetylcholinesterase inhibitors. So before starting empirical therapy with varoloctibidol, we should be little cautious in this type. Let us discuss a case scenario here. So this child presented to us by 5.5 months with stridor and respiratory distress right from neonatal period. So child was admitted in NICU for about a month with a diagnosis of neonatal sepsis. See, many a time what happens is these children, because of the hypotonia and all, they will have birth asphyxia. If you do an MRI can show HIE changes. So by looking at the HIE and all, we cannot leave them because we should look for other signs, dysmorphic features, hypotonia. Any child with severe HIE changes, persistent hypotonia, more than 6 months. So we should look for neuromuscular issue, especially this congenital myasthenic syndrome. So the child was admitted in multiple times for acute respiratory distress. And then what happens, ENT evaluation showed vocal cord palsy. So we thought of a diagnosis of CMT, Charcot-Marie-Tooth disease with vocal cord palsy was a clinical diagnosis because the reflexes were depressed in acute phase. What happens was, then later what happens was, there was general hypotonia, the sluggish pupil reflex, and respiratory and bulbar progressive. There was feeding difficulty. Child was put on gastrostomy, then and tracheostomy too. So, but whole exome sequencing revealed CALQ mutation. So both parents are also heterozygous, confirming the diagnosis. So probably it's a CALQ-related congenital myasthenic syndrome, homozygous. The treatment was salbutamol. So child was started on salbutamol. There was a marked respiratory improvement and progressive stabilization. 5 years of age child recently was admitted for tracheostomy closure and decannulation. But what happened was the salbutamol was stopped by the parent. The parents said the child had some tremors and that adverse effect because of the adverse effect of salbutamol, we stopped on their own for about 2 years. So the weakness worsened. The child was restarted on salbutamol, the weakness improved. So any child with severe neonatal respiratory presentation with bulbar dysfunction, hypotonia, fatigabilitosis, and dramatic salbutamol response, think of CALQ-related congenital myasthenic syndrome. So this is the child, this is the father and mother, they are heterozygous, they were asymptomatic carrier. Coming to postsynaptic CMS, commonly it is due to acetylcholine receptor deficiency. Loss of function mutation causes, commonly it is due to CHRNE mutation. Usually what happens is acetylcholine has 5 subunits, 2 alpha, 1 beta, 1 delta, 1 epsilon. Usually in the fetal life, it will be replaced by gamma subunit. This may give some protection in the fetal life. So in the adult, when it's getting replaced later, the symptoms starts manifesting. Ptosis and ophthalmoperisis with fatigable limb or bulbar weakness from infancy or early childhood can happen. They are stable and non-progressive. They have excellent response to acetylcholinesterase inhibitor usually and 3,4-diaminopyrrolidine. So usually it was the first gene to test with a classical ocular plus fatigable phenotype and a good peridostigmine response. Coming next to slow channel syndrome. It was first discovered by Engel et al. In 1982. It's an autosomal dominant gain of function mutation. Because of this, what happens is because of the gain of function mutation, there will be prolonged channel opening and slow decay of the young plaque currents. What happens is there will be cationic overload and the muscle fibers are repetitively stimulated. So onset of symptoms from infancy to adulthood, early cervical, scapular, wrist and finger extensors are weakness. It is a characteristic finding in slow channel syndrome. And ptosis and ophthalmoplegia are less prominent. Upper limbs are weaker than lower limbs. The weakness is slowly progressive. So in this syndrome, and CALQ, if you do nerve conduction, you can see double peak appearance. So it is characteristic of these two findings because of the repetitive stimulation. So 3,4-DAP and acylcarnitine inhibitors worsen this condition. It distinguishes from autoimmune myasthenia and other forms of CMS. So quinidine or fluoxetine can be tried. They partially correct prolonged acetylcholine receptor activation, so they are useful monitoring the adverse effect. Quinidine is not so much tolerated in children, so we try fluoxetine. For fast channel, it's a loss of function mutation. There's a rapid decay of in-plate currents and there'll be brief channel activation episodes that reduce the probability of channel opening in response to acetylcholine, resulting in reduced miniature in-plate potential. So there will be ophthalmoparesis, bulbar weakness, and exertional weakness. They respond favorably to acetylcholine extrases and 3,4-diimmunopyridine. So these are same receptor opposite pharmacology. This autosomal dominant CHRNE mutation, CHRA1 mutation is a gain of function mutation. Whereas this autosomal recessive inheritance is a loss of function mutation. So you can find out the selective weakness of asymmetric neck, wrist, and finger extensor weakness. Double response to single nerve stimuli, as I already told you, they respond to fluoxetine and quinidine. These group fast channel syndrome, they respond more to pyridostigmine and 3,4-diimmunopyridine. Oh, I see. So coming to other RAPs in DOK and end-plate developmental, these are also other mutations we may come across in relation to congenital myasthenic syndrome. The presentations are rhapsody is common cause in infancy. This is also going to be recurring apneic episodes. So there will be fetal akinesia and deformation sequence, and they may have arthrogryposis. They are acylcarnitine responsive. DOC7 limb girdle presentation with they may progress to respiratory decline in the second decade. They may have waggling gait, no ophthalmoparesis, but pupillary response may be sluggish. Musk, rare cause, they respond to salbutamol and ephedrine. Coming to this case scenario, this 11-month-old boy present to us with 1 to 3 degree. See, consanguinity is important in all these children because if there is any history of consanguinity and history of abortion, even we have to do genetic evaluation for CMS because all are autosomal dominant or autosomal recessive inheritance. This is a term child born by cesarean section, 3rd-degree consanguineous parents, admitted NICU for hypotonia and aspiration for about a month. So at 7 months, the child had poor waking and persistent generalized hypotonia. And then recurring bulbar weakness or recurring aspiration was there, drooling was there. And MRI when showed mild non-specific hypomyelination, I was normal. So genetic showed CHRNE mutation. So this is a CHRNE related congenital myasthenic syndrome, post-synaptic acylcarnitine receptor deficiency. So there, the child had hypotonia, bulbar movement with consanguinity. So pyridostigmine was started. Child showed improvement in bulbar function, feeding and aspiration. So functions improved, though there is subtle weakness, but still the child improved. So there's unexplained hypotonia, recurring aspiration with bulbar weakness, considers CMS even with non-specific MRI finding. As I already told you, MRI may show HIE changes in case of severe hypoxia because of the hypotonia, but even then we should evaluate them for CMS with genetics. Genetics is nowadays easy to do than do RNS in children, especially in infants. Pyridostigmine is highly effective in this condition. So this was a genetic finding, likely pathogeny. This other child, 4-month-old boy with CHRNE mutation, congenital myasthenic syndrome, likely pathogeny. The child had some subtle dysmorphic features also. Previous history of abortion was there in this child. Coming to glycosylation defect, they are very rare. They are upcoming nowadays. Many mutations are being detected, especially in India than other population. So there's a defective N-linked glycosylation impairs the maturation, trafficking, and clustering of receptors and other NMJ proteins. Usually they present with a limb girdle type, mimics LGMD or DOC7 CMS. Muscle biopsy, if you do, even may show tubular aggregates. And that usually there will be deformity, maybe the scoliosis can be there, respiratory issues may be there. If you do CPK, it will be high in this GMPBB gene mutation. Favorable responding to acetylcholine esterase inhibitor and salbutamol 2. Coming to this case scenario, this 16-year-old child presented difficulty in walking since the age of 3 and developmental delay. At 5 years, the child had limb girdle pattern of weakness with waggling gait. Child was tested genetically, it was negative. So muscle biopsy showed congenital fiber type disproportion. The child was followed up regularly with this diagnosis, congenital fiber, muscle fiber type disproportion. And 16 years progressive worsening of weakness and more pronounced limb girdle distribution weakness. So what happens is when the genetics was repeated, so what happens is day by day there are so many genes are being detected. So if the child is negative at one point of time, it is better to repeat after some time because the genetic, though so many numbers have been detected, number one. Number two, sometimes very tough uncertain situation may be going to likely pathogenic or maybe be classified to pathogenic variety based on the clinical picture of evolving clinical pictures. So it is better to repeat if you strongly suspect congenital myasthenic syndrome, even though the initial genetics is negative and even otherwise the initial findings are not typical of CMS. So treatment pyridostigmine was initiated. The child showed good improvement with limb girdle weakness and then functional motor performance improved. So CMS can mimic progressive limb girdle muscular dystrophy. The negative initial genetic test and non-specific biopsy should not exclude CMS. So persistent suspicion warrants repeat testing. And then even in genetic testing, we should make sure that the genetic panel covers 100% of congenital myasthenic syndrome panel. So usually it will be given at the end. The child showed DPGT1 variant of mutation of CMS. So congenital myasthenic syndrome type 13, autosomal recessive of VUS. So some of the I have watched what I already discussed, genotype phenotype correlation at a glance. The presynaptic chart mutation common, present with episodic apnea, episodic cry, normal intellectual examination, they may evolve into adults. The the good response to predostigmine. Synaptic calcu mutation, there will be progressive proximal weakness, ocular involvement, sluggish pupillary reaction. They worsen with predostigmine, which better to avoid. Postsynaptic acetylcholine receptor deficiency, CHRNE mutation, they present with ptosis and ophthalmoparesis. They have a stable course. Slow channel mutation, CHRNA1 dominant, they may have selective muscle weakness of neck, wrist, finger extensors. They worsens, the quinidine and fluoxetine may be tried. DOX7 mutation, once again they present with limb girdle type. They can have ptosis but no ophthalmoplegia. They usually what happens, the pyridostigmine may worsen, salbutamol may be tried. Rhabsin mutation once again can have apneic crisis. They can have arthrogryphosis. They show good response to pyridostigmine. And glycosylation once again present with limb girdle. So glycosylation defects, rhabsin mutation defects, like glycosylation, DOX7 can present as limb girdle type of myasthenia-like syndrome apart from this call-Q. So the fatigable weakness, right, history right from birth to early childhood into adulthood. Ptosis. Ptosis is the single most common presenting sign. Any child with hypotonia with ptosis, we should think of CMS. So ophthalmoplegia is frequent but not universal in all the types, especially in DOX7. They can have bulbar weakness. Associated clues, they can have cognition may be normal. There will be delayed milestones. There will be history of recurrent abortions. Consanguinity may be there. Beyond neuromuscular junction, some CMS genes are associated with the dysmorphic features, or they have associated with oculomotor apraxia, they have macrocephaly, they may have GA symptom, they have skin fragility and all these things. So they may have, these genes can have other association too. So look for other dysmorphic features, they cannot exclude. Process of cystinuria cannot exclude this type of CMS. So what else can mimic CMS? Seronegative myasthenia, spinal muscular atrophy, and congenital myopathies, especially anomaly not centronuclear, because the centronuclear myopathies can have normal CPK. So like what we say, a normal CPK cannot rule out myopathy. Likewise, this can mimic. So mitochondrial disease can mimic CMS, and congenital muscular dystrophies, though they may have elevated CK, so they may mimic CMS. So bedside assessment, as we know, this are usually fatigability testing difficult to do in children, but anyhow better to do with the older child. All these children should be followed with pulmonary functions. So which may be affected. In some time there may be scoliosis which can cause respiratory distress. So you look for sluggish pupillary response. Serum CK may be elevated in GMPBB mutation. So even elevated CK in a child, hypotonic child, will not exclude CMS 100%. So these antibodies, usually they are negative, but nowadays there are case reports that antibodies are associated. Sometimes in few literature, they say thymic hyperplasia and ACH antibody positivity, they are treated well with these immunoglobulins, etc. Of a few case reports, it is seen. So this I already told you, incidental coexisting seropositivity or genuine dual pathology. CSR is CMS. In the one literature, they showed the thymic hyperplasia, the child had thymic hyperplasia, positive for autoimmune, which they attributed secondary myasthenia. So this already discussed a double response on the conducted study in congenital myasthenic syndrome. I'll just skip. So usually 4 drug classes: pyridostigmine, 3,4-dihydropyridine, salbutamol or ephedrine, or quinidine or fluoxetine. These are the drugs commonly used with congenital myasthenic syndrome. So this is already discussed. So there are so many engaged cohort in CMC. Velour study showed nearly 25 patients in 2018. In 21 studies in 2019 have been published. In Mumbai, Professor Kadirkar's group published on 15 patients. And the largest Indian cohort published in Brain from Bangalore, 156 patients for 41 families. Found in literatures. In 14, nearly 50% had consanguinity. Under the Indian population, as I already told you, glycolytic defects are strikingly frequent in children than in Western population. So the algorithm will be recognize the fluctuating weakness, suspect strong suspicion is necessary for CMS, confirm by RNS. Even by RNS, if the limbs are normal, go for trapezius and facial muscles, which is difficult to do in infants and young children. So exclude acquired myasthenia. Then genetic panel, you just make sure that the genetic panel 100% covers the CMS panel, and then we have to choose the drug accordingly. Then once diagnosed, the child needs to be followed up on preferably the respiratory muscles and bulbar muscles and family counseling. So once again reiterate, DOC7 present with limb girdle weakness, waggling gait, ptosis. Usually ophthalmopathies may be absent. The acylcarnitine pyridostigmine worsens the condition. Call-Q, proximal weakness, respiratory involvement, pyridostigmine can worsen. These can have high CPK and myopathic feature, and myasthenic phenotype plus myopathy can coexist. So rhabsin mutation, neonatal respiratory failure, and episodic apnea, though episodic apnea can happen with CHAC mutation. Slow channel receptors, selective weakness of neck muscles, wrist and finger extensors, and progressive ventilatory insufficiency, they can go into adulthood. In adult, they can commonly see the slow channel also. So pyridostigmine can worsen. So CHAC pre-synaptic CMS with episodic apnea, episodic cry, incessant cry with hypotonia triggered by infection. Any infection precipitate weakness, child used to get admitted in ICU. So many ICU admissions, in spite of that, child may recover and reaches adulthood. So this is a typical pattern of this CHAC mutation. So take home message is that CMS is genetic, strong suspicion is needed. It should be considered any adult or child with seronegative myasthenia with poor response to pyridostigmine, especially with history of consanguinity and history of abortions. Therapy guided by genetic defects. Absence of ophthalmoplegia or negative first genetic panel does not exclude CMS. Empirically, static pyridostigmine can worsen CALQ, DOC, and MUSC, AGRN, and slow channel CMS. Indian cohort shows distinctive high CHRNE and glycosylation burden and low rhabsin mutation. Most CMS is treatable. If you start early, it changes the natural history. Thank you. Thank you, sir. I think stick to the timing.
Thank you, sir. That was a very elaborate talk on congenital myasthenic syndromes. Mhm. Sir, one thing is when we come across a floppy infant, what are the key points in the history and examination to check for fatigability?
Yes, sir. No, fatigabilities are usually children may not present with history of fatigability at all. Usually, if this Older child, they can say child gets
Nandri.
tired in the evening, especially in the PT period. Suppose in the child, usually in the classes, physical education classes, child may not participate 100%. That history will be there with the in a young child, not in younger one. Sometimes what happens is the feeding. The child starts taking feeding. In fact, gradually after some time, the child may have nasal irrigation in severe forms. So that may indicate the fatigability.
Infants, sir. Infants, any clues?
That's why, in fact, there'll be generalized hypotonia, number one.
Yeah.
On the presentation, the neonatal period, there'll be the disease is severe. They can have birth asphyxia and all MRI may show hypoxic changes. But usually what happens in any child with a pyramidal lesion, more than 6 months, there should be spasticity as the myelination progresses. But persistent hypotonia, in spite of that, in spite of pyramidal lesion, in spite of MRI showing HIE changes, even by more than 6 months, it should strongly makes us to suspect any neuromuscular issue, especially CMS and congenital myopathy. So CMS should be suspected in such children. And one more thing is feeding issues. So whenever the child starts feeding, the gaps. So what we say is that feeding difficulty can happen with cardiac issues. What happens in congenital myasthenia because of the fatigue, as the child starts taking feeds, gradually what happens, the child may have respiratory distress. That can give us a clue in early infancy about the fatigability.
Thank you, sir.
Excellent lecture, sir.
Thank you, sir.
You covered all the aspects.
Right.
It is many times we have listened to this, and always at the end we will feel confused. But you have covered almost all. Thank you. So how do you go about? For example, you generally we start with pyridostigmine only, and and we warn them that the child may worsen. How do you go about, sir, if they, how long, for example, they say for salbutamol, we have to wait for some 1 or 2 months to look for the response. How you assess the response and how do you go about the treatment plan, sir?
So usually, sir, this I already showed 2 patients. They are in tracheostomy as well as feeding gastrostomy. Usually in the ICU before discharge, they used to have, because the child is anyhow having hypotonia and feeding issues, to prevent further aspiration. But the thing is, gradually what happens, tone will improve. The child will be alert, then movement will improve, sir. But the problem will be this with our parents, they stop therapy. Even in salbutamol also, the child may have tremor and then stop. Only thing is the pyridostigmine the children tolerate better than adults. So whatever, even one of my patients, their mother, she used to titrate the pyridostigmine. Even we don't prescribe such a dose. The child is on morning 2 tablet, afternoon 1, evening 2. So this type of this, she used to escalate and she used to discuss because the child is on long-term pyridostigmine. She says, whenever she sees the evening worsening of weakness, then immediately she increases the doses. Till now, without any adverse effect.
Thank you.
That's the thing.
Thank
So the usually they lose I have follow up of only very few patients. Many what to say they don't want to take long term salbutamol or long term pyridostigmine. They may present once again with ICU. So whenever we diagnose, we counsel them. Then the child should be put on drugs continuously without any lifelong.
Yes, sir, I have a few patients on follow-up, sir. Sir, did you ever have the chance of giving 3,4 diaminopirin? Because
No.
I haven't tried. I have
Availability and
not
then
available.
this ephedrine, we had one patient right the newborn, right from newborn we tried, they got it from abroad. Even they used to call me, and then if anybody needs to just tell us, sir, we'll arrange for ephedrine, something like that. So that we have used, but not thimerosal.
Okay, thank you, sir. Thank you.
How you decide whether to start on pyridostigmine or it's not pyridostigmine responsive? Any clinical clues, sir?
So usually, sir, some, as I already told you, some genetics may get worsened. They will worsen with pyridostigmine.
Yeah.
Usually, we go for genetic testing based on the gene only. We'll start. We don't start empirically with pyridostigmine, even in ICU setup.
So we have to wait till genetic analysis.
Sometimes nowadays rapid exome sequence is available. They give results in 10 days. So based on it, once the child is admitted in ICU, one of the second CHRNE was rapid exome sequencing in ICU. So if the gene is responding to pyridostigmine, then only we'll start. We don't start empirically.
Thank you, sir.
Thank you.
I think there is a question in the chat box. Dr. You click the chat box, there is one question I could see. question and answer. You click the question and answer. There is one question is there. Q&A.
Let me check, sir. Yeah.
one
There are
question,
two messages. Two says excellent, sir. And one is
Thank
in
you.
slow channel CMS, after how much time of starting fluoxetine and what minimal dose of fluoxetine can we expect clinical response before we increase the dose? After how long we should increase the dose and what is the minimum dose? That's the question, sir.
Sir, the problem with the fluoxetine is usually we start slowly. I have tried only once. The patient did not. Usually we can go up to 80 milligram in children, sir. But the thing is, they don't want to start fluoxetine at all. Once we start fluoxetine, they see the chat GPT and all. They say, sir, this drug is not for my child. Something I had the opportunity to start in only one, but the parent refused. So I don't have any experience of continuing fluoxetine therapy in any child.
What is the minimum dose, sir? That's the question. With what dose can we start?
No, sir, I don't have any experience at all now.
Okay.
Yeah. Regarding
I have one patient and who have a DOX7 mutation and diagnosed as motor neuron disease in the wheelchair for 25 years. And at the age of 60, I saw, and the genetic test was positive. I put him on fluoxetine and I went up to 60 mg daily. He had a significant improvement. Adult patient. Pediatric, I don't know. I think pediatric we have to give as per body weight actually.
Body weight, but still the problem is acceptance.
Yeah, they will search the net and think this is an antipsychotic.
Nowadays there is even sodium valproate.
Yes.
Good evening, sir. Can I ask some questions, sir?
Yes, sir.
Sir, I'm Dr. Alim.
Yes, sir.
Sir, first of all, I thank the speakers for giving an excellent talk on the rare disorder, particularly neuromuscular disorder, sir.
Thank you, sir.
Particularly, I am very much thankful to Professor Palni discussing a rare subject, yoga in these disorders. Because he is the chair for the yoga group of World Federation of Neurology, as well as he is one of the advisors for our central government committee formed for the yoga promotions. I want to have some few points on this disease and yoga, sir. In patients with mild, moderate, severe mental abnormality with this rare disorder, is there any specific yoga procedure through audio visual or through by demonstration is possible to improve their mentation, sir?
The important thing in any procedure is the ability to understand what the instructions. I think many times people with cerebral palsy or people with multiple phenotypic issues, and we always assess the cognitive function. I think we know that many neuromuscular disorder patients can have additional cognitive issue. And but whatever I seen or I train the people, many are able to understand simple instructions. We don't give complicated instructions to these kids. Adults also like that. So they may know, take a deep breath in, take a deep breath out, up your arm, down your arm, stretch your body, and take say like the sound kind of sound meditation, or listening to music. So those kind of, you have to modify. The yoga therapy is basically you have to design what is ideal for a particular patient for the particular disease. So separate consultation is needed that what to be practiced and that to be done routinely. So that's how we do things.
Thank you. Thank you so much, sir. Thank you, sir. Thanks.
Sir, over to Pani, sir, for conclusion.
Thank you, chairpersons. I thank Dr. Muthu, Professor Salim, and Dr. Ramakrishnan from Coimbatore, and Ashmita, who organized all this link and everything, communicated to people. Thank you very much, Ashmita. And I thank Indian Academy of Neurology for this program. We will continue to do this program. And we know that going to be recorded and will be circulated among the members, and many people will see subsequently after this. So one kind of dissipating the knowledge. And I thanks once again to everyone. I'll hand over the mic to Dr. Magesh for concluding and thanking people.
Thank you, sir. Thank you, sir. We had a nice discussion on both the topics, yoga as well as congenital myasthenic syndrome. Hope we will continue this type of events at least once in 2 months in future also. Thank you for IAM. Thank you for the Dr. Thank you, Ashmita and digital team for your help. Thank you. Thanks a lot.
Thank you,
Thank you,
sir.
sir.
Thank
Thank you so
Thanks
much,
for
sir.
the
Thank you.
Thank you.
Thank you. I thank audience.
Thank you
All the
for the
audience who
fun, sir.
participated.
Thank you, sir.
They are
Thank you, sir.
most of them are, many are very highly intellectuals who spare their time and joined with us. Thank you very much.
Thank you. Thank you, sir.
Thank you, sir. Thank you.